In this lesson, we will cover deciding whether to have surgery, what decompression surgery entails, surgical and non-surgical outcomes, the surgical experience, and residual symptoms. Unfortunately, when it comes to Chiari, there are not a lot of treatment options. The only real treatment is surgery, performed by a neurosurgeon to relieve the pressure caused by the herniated tonsils. Because of this, deciding on treatment boils down to deciding on whether to have surgery or not. By default then, absent surgery, the only other option is to wait and see what happens and manage individual symptoms as best you can. While it seems like a simple situation with only one decision to make, the reality is that in some cases, the decision of whether to have surgery or not can become quite complicated. This is partly because the surgical decision involves both the patient, or the parents in the case of a child, and the doctor, both of whom must agree to proceed with surgery. In making this decision, each party will look at it from their own point of view and consider both objective and subjective factors. The patient must decide how much their symptoms are impacting their quality of life, how they feel about the risk of the procedure, and how much faith they have in their doctor. Some people are eager to have surgery, while for others, the thought of it is too overwhelming to consider, even in the face of severe symptoms. Meanwhile, the doctor will decide based on the patient's reported symptoms, what the imaging shows, whether there are clear signs the nervous system is being affected, and their own experience in treating Chiari. It may be surprising, but when evaluating Chiari, neurosurgeons will often recommend surgery less than half of the time. Unfortunately for patients, research has shown that surgeons often disagree on when surgery should be recommended. So, while some cases are straightforward, many are not. From a practical point of view, this means that if a patient or family seeks additional opinions, they need to be prepared to hear different things from different doctors. In those situations, the burden shifts to the patient in deciding which opinion they feel the most comfortable with. Next, let's look at what the surgery entails, and then we will talk about the surgical experience for patients. Chiari surgery is often referred to as decompression surgery. Decompression is shorthand for posterior fossa decompression, which is the technical name for Chiari surgery. The posterior fossa is the region of the skull where the cerebellum is situated, and decompression refers to making more space around the herniated cerebellar tonsils. Decompression surgery has two major goals. The first is to create more space around the herniated tonsils so that neural tissue is not being squeezed, and the second is to restore the natural flow of cerebrospinal fluid. While in general this is accomplished in several steps, it is important to note that there are many variations, some minor and some major. We will highlight some of the more common major variations. But before undergoing surgery, patients and parents should make sure they have a clear understanding from their surgeon of what specifically will be done and why. The first part of the surgery involves removing bone from the skull and spine. After the patient is prepped for surgery, they are placed on the operating table and their head is secured in a clamp. Next, an incision is made down the center of the back of the skull from near the top down to the top area of the neck. Once the skull or cranium is exposed, a piece of it near the bottom is removed. This is called a craniectomy. The amount of bone removed may vary, but for an adult, it is usually between 3 to 4 centimeters in length. In addition, the surgeon will likely also remove a piece of the top vertebra in what's called a laminectomy. If the herniation is large, part of the second vertebra may be removed as well. In some cases, especially among children, this is all that will be done. This type of surgery is called a bone-only decompression. The advantages and disadvantages of bone-only decompressions will be reviewed a little later, but for now, let's assume the surgery will continue. With the bone removed, the dura, or covering of the brain and spinal cord, is exposed. The dura is cut and pulled back in an upside-down triangle shape, exposing where the spinal fluid flows and also the cerebellar tonsils themselves. This allows the surgeon to look for and remove any adhesions or scars that are interfering with the flow of the spinal fluid. In addition, some surgeons will choose to reduce the size of the tonsils themselves by cauterizing them. Next, in what is called a duroplasty, a patch is sewn over the dural opening, essentially expanding the space underneath and providing more room for the tonsils and spinal fluid. The specific material that is used for the patch again varies from surgeon to surgeon. Some surgeons like to use tissue taken from the patient, while others will use one of several commercial dural substitute products. Then, before closing everything up, some surgeons will attach a special metal plate to replace the cranial bone that was removed and give the neck muscles something to attach to other than the dura. Finally, the surgical site is closed in layers and stapled shut down the initial incision. This gives the appearance of a zipper on the patient's skull and has led to the term zipper head being used among some in the Chiari community to refer to patients who have undergone surgery. While decompression surgery is the standard treatment for Chiari, some patients may face other procedures as well. According to the Chiari 1000, 13% of patients, both children and adults, also had a shunt placed in the brain to divert spinal fluid. A similar percentage had stabilization of the cervical spine, and nearly 5% underwent a tethered cord release. In all, more than 1 in 4 surgical patients reported having more than one Chiari-related procedure, and 15% reported having more than 2. As with any procedure, Chiari decompression surgery involves risks, and complications can and do occur. Therefore, it is very important that patients and parents understand the risks involved before deciding to have surgery. How often complications occur with decompression surgery isn't entirely clear, and depends somewhat on the source of the data. When surgeons publish papers based on their own case series, they often report complication rates of 5% or less, and a database maintained by the American College of Surgeons showed a similar complication rate for 1,500 pediatric surgical cases. However, studies based on hospital records tend to show higher complication rates. One such study found that of 900 pediatric Chiari surgeries across 3 states, there was a 90-day complication rate of nearly 13%. Similarly, a 10-year study of over 13,000 pediatric cases found a complication rate of over 8%. For adults, studies have found the complication rate can be as high as 18%, and that nearly 1 in 10 adults are readmitted to the hospital within 30 days. The most common complications are infections and CSF leaks. Infections are a problem for any hospital procedure, but CSF leaks arise because it can be difficult to get a watertight seal when placing the dural patch. One of the more puzzling and troubling complications is hydrocephalus, or excess fluid in the brain. For unknown reasons, this occurs after about 5% of Chiari surgeries in both children and adults. Unfortunately, in these cases, 4 out of 5 patients will require a permanent shunt to be placed in the brain to divert the extra fluid. Now that we have a picture of some of the potential complications, let's circle back to the question of opening the dura during surgery. As mentioned, in recent years, some surgeons have explored performing decompressions where the dura isn't opened, or at least not fully opened. While there has been extensive research comparing the two approaches, a definitive answer has not emerged. Rather, it appears that there are pros and cons to each. Specifically, not opening the dura dramatically reduces the chance of surgical complications and results in shorter hospital stays and less pain. However, there is an increased risk of needing a second operation where the dura will likely be opened to achieve good results. On the other hand, opening the dura increases the risk of surgical complications and results in longer hospital stays, but is also more likely to be successful the first time. Therefore, while bone-only decompressions have become more popular in pediatric cases, they are not as commonly used for adults. Now that we have covered the 2 treatment options, surgery or no surgery, let's look at how patients do with each. For those in the no surgery or wait-and-see group, one way to assess outcomes is to see how often surgery is required in the future. For pediatric cases, studies have shown that in the medium term, meaning several years, less than 10% of conservatively treated children end up requiring surgery. In addition, for children who do not have symptoms when the herniation is identified, only 5% develop any symptoms or neurological deficits over time. There are 2 important caveats to this. First, no study has followed incidentally diagnosed or conservatively treated children into adulthood, so it is possible that some of these cases become symptomatic as adults. The second is that parents should be aware that when children are monitored with regular MRIs, it is very common for the amount of herniation to change from year to year. While this is valuable data for pediatric cases, less data is available on conservatively treated adults. However, one study that involved both children and adults treated conservatively found that the children did much better than the adults, with 95% of the kids remaining stable, compared to 64% of the adults. For surgical outcomes, there are several options for measuring outcomes. The most common, although perhaps not the most useful for patients, is the general clinical impression of the surgeon. This is often reported as improved, no change, or worse. There are many published studies like this, and in general, surgeons report improvement 80 to 85% of the time for both children and adults. But what does improved mean? A couple of studies have gone further and added the category of resolved to their reports, based on very limited numbers. Close to half of children and 20% of adults experienced complete resolution of their symptoms after surgery. A second way to measure surgical outcomes is by using any number of health-related scales, including the Chicago Chiari Outcome Scale, which, as the name implies, was designed specifically for Chiari. Results from these types of studies are generally in line with the clinical impression type findings, in that about 80% of patients will score as improved or having a good outcome. Not surprisingly, they have also shown that in general, kids have better outcomes than adults. A third way to measure outcomes is to ask patients directly how the surgery impacted their symptoms. Patient-reported studies, including the Chiari 1000, show that 40 to 45% of adult patients report a significant improvement in symptoms, and another 20 to 30% report a slight improvement. While these results are not quite as good as when doctors report outcomes, the same studies indicate that knowing the outcome in advance, 80 to 90% of patients would choose to have the surgery again. Finally, we can look at symptom-specific improvement. While Chiari patients often suffer from many symptoms, research has clearly demonstrated that headaches, especially cough or Valsalva headaches, are the most likely symptom to improve with surgery. Decompression surgery is also effective at reducing the size of or eliminating syrinxes, where fluid collects in the tissue of the spine itself. This is important because syrinxes can lead to nerve damage and even paralysis if not treated. Decompression surgery has also proven to be effective in improving sleep apnea. However, for many Chiari-related symptoms, such as visual disturbances and balance issues, the results are mixed, with improvements only seen about half the time or less. One common question that people have is whether it is possible to predict who will do well with surgery and who won't. While many researchers have tried to find an objective way to accomplish this, unfortunately at this point in time it is not possible. However, certain factors have been shown to negatively affect outcomes. As previously mentioned, children tend to do better than adults in terms of symptom improvement. In addition, people with certain related conditions, such as syringomyelia or Ehlers-Danlos syndrome, tend to have poorer outcomes than patients with simpler cases. Time before diagnosis appears to be a very important factor as well, with adults who experience symptoms for more than 2 years before surgery having significantly poorer outcomes. Finally, surgical skill is also important, as studies have shown that outcomes, even within the same practice, vary from surgeon to surgeon. These are just some of the factors that have been shown to be related to surgical outcome, but there are likely many more. As is clear in looking at the outcomes data, sometimes surgery fails to improve symptoms at all. This can happen for a number of reasons. One possibility is that the surgery itself did not provide enough room, meaning not enough bone was removed or the dura wasn't opened. Failure can also occur due to surgical complications, such as issues with the dural patch or the development of hydrocephalus. Another possibility is that the patient's primary symptoms were actually due to something other than Chiari. Regardless of the reason for the initial failure, up to 15% of Chiari patients will undergo a second decompression. Now that we've reviewed the technical aspects of Chiari surgery, let's look at what the experience is like for patients. While the experience will vary from person to person based on what specifically is done, whether there are surgical complications, and what the patient's overall health is going into surgery, it is important to realize that Chiari decompression is major surgery performed under general anesthesia. Before the surgery, there will likely be preoperative testing, and of course the hair on the back of the head is shaved where the surgeon will cut. In general, the procedure itself can take a few hours, and patients will likely spend at least one night in the intensive care unit, where it can be quite shocking for family members to see their loved one. After patients are moved to a regular room, they will likely stay in the hospital for another couple of days. For example, one study found that 75% of pediatric patients were discharged by day 4. However, another study found that 1 in 4 adults visit the ER at least once within 30 days of discharge, most commonly for headaches or CSF-related issues. So it is important not to leave too soon. A detailed discussion of recovery is beyond the scope of this lesson, but while most people can recover from the surgery itself in a matter of weeks or months, it can take years for the nervous system to recover from the effects of Chiari itself. And while a lot of children may bounce back fully, research has shown that most adults will not. Specifically, pain, depression, anxiety, and neck-related disability are common for adult patients. even after what may be considered a successful surgery. For example, Chiari research has shown that 80% of adult women with Chiari experience at least moderate levels of neck-related disability, whether they have had surgery or not. This means that the vast majority of adult patients struggle with one or more aspects of daily living. Something else patients should be aware of is that symptoms can come back over time. Good data on this subject doesn't exist for kids, but among adults, a large German study found that 10 years after surgery, 15% of the patients had experienced neurological deterioration. To summarize, the primary treatment for Chiari is posterior fossa decompression surgery. Many surgeons disagree on when surgery should be recommended. The most common complications after surgery are infections and CSF leaks. While bone-only decompressions are popular in pediatric cases, they are not as commonly used for adults. In general, symptoms will improve with surgery about 80% of the time. Valsalva headaches are the most likely symptom to improve with surgery. At this time, it is not possible to predict who will and who will not do well with surgery. While most people can recover from surgery in a matter of weeks or months, it can take years for the nervous system to recover. Pain, depression, anxiety, and neck-related disability are common for adult patients, even after a successful surgery.